Alrighty, guys, welcome to one more podcast. Today we're talking about lungs, pleura, and more things after an hour or two. So, yeah, um, ChatGPT, are you here?
Hey there. Yep, I'm here and ready to dive into all things lungs and pleura. Where do you want to start?
Perfect. What's the difference between thorax, thoracic cage, and thoracic cavity?
Great question. So, the thorax is basically the entire chest region. The thoracic cage refers to the bony structure, ribs, sternum, and spine that protects your organs. And the thoracic cavity is the space inside the cage where your lungs, heart, and other structures sit.
Dude, that was a perfect explanation.
Glad it helped. Anything specific you want to dive into next?
Yeah, let's talk about the development of the respiratory system.
All right. So the respiratory system starts developing around the fourth week of embryonic life. It begins with a lung bud that branches out from the foregut, eventually forming the trachea, bronchi, and lungs. By birth, the lungs are ready to inflate and start gas exchange.
So, um, so we have an endodermal bud from a gut tube first.
Exactly. The lung bud comes from the endoderm layer of the gut tube. This bud then grows and branches to form the trachea, bronchi, and eventually the lungs.
What's a gut tube?
The gut tube is a simple tube formed during early embryonic development. It later differentiates into the digestive and respiratory tracts. So, parts of the gut tube give rise to the esophagus, stomach, intestines, and also the respiratory system.
Wait, what?
No worries. Take your time.
Tell me again, tell me again. What's the gut tube?
Sure, the gut tube is a simple tube that forms early in an embryo. It eventually becomes the digestive tract, including the esophagus, stomach, and intestines, and also gives rise to parts of the respiratory system.
Wow, and why does it start as a tube?
Well, during early development, cells organize into layers. The gut tube forms from the endoderm layer, creating a simple tube that will eventually specialize into different parts of the digestive and respiratory systems.
I don't understand.
Great. Anything else you'd like to
Sir,
cover about the rest?
sir, I said I do not understand.
Got it. So imagine early development like a basic blueprint. The gut tube is that initial simple structure that will later form your digestive organs and part of your respiratory system. It's like the starting point that eventually gets more complex as the embryo develops.
Mm-hmm.
It's a lot to take in, I know. Feel free to ask about anything specific if you'd like more detail.
So what's the endodermal bud?
The endodermal bud, or lung bud, is a small outgrowth from the endoderm layer that will develop into the lungs and airways. It starts as a simple structure and branches out to form the trachea, bronchi, and eventually the lungs.
And why did nature and evolution choose the endodermal bud to be the ancestor of these?
Well, the endoderm layer gives rise to many internal organs. It's thought that having a single layer develop both the digestive and respiratory systems was efficient. Nature often favors simplicity and functionality. So, this arrangement worked well through evolution.
Okay, so we will form tracheoesophageal septum, which will separation between dorsal foregut, esophagus, and ventral respiratory tube, larynx, trachea, and lungs. Why is the dorsal foregut called esophagus, and why are the ventral respiratory tube called larynx, trachea, and lungs?
Great observation. The dorsal foregut becomes the esophagus because it's positioned towards the back or dorsal side of the embryo. The ventral part, which is more towards the front, develops into the larynx, trachea, and lungs because it buds off from the foregut and specializes in forming the respiratory tract. This division allows both systems to function properly.
What does ventral mean, and what does dorsal foregut mean?
Ventral means the front or belly side, while dorsal refers to the gack side. So the dorsal foregut is the back part of the early gut tube that becomes the esophagus, while the ventral side forms the respiratory structures.
Tell me again.
Sure, ventral means the front or belly side of the body, while dorsal is the backside. So the dorsal foregut is the part at the back that becomes the
So,
esophagus.
so ventral is anterior,
Exactly. Ventral is anterior, meaning towards the front.
and dorsal is posterior.
Yep, dorsal means posterior, towards the back.
Etymology?
Sure, ventral comes from the Latin venter, meaning belly, and dorsal is from dorsum, meaning back.
Okay.
Pretty straightforward, right?
I guess so. So we have a cephalic end and a caudal, and a cephalic is towards the head.
Exactly. Cephalic means towards the head, and caudal means towards the tail or lower end.
Why
This
does
terminology,
caudal mean towards the tail?
caudal, comes from the Latin word cauda, meaning tail. It's used to describe anything towards the lower end or rear, especially in animals and embryology.
Interesting.
Exactly. It's all about orientation.
And then the long bud splits into bronchial buds.
Yup, the lung bud branches into bronchial buds, which form the bronchi and continue branching into smaller airways.
Then they form the respiratory tree. Uh, uh,
Exactly.
three
You
right
got it.
lobes, two left lobes.
Exactly. 3 lobes on the right, 2 on the left, to make room for the heart.
And then branches and divides down to terminal bronchioles.
Exactly. The bronchi divide into smaller bronchioles, ending in terminal bronchioles, which lead to the
Okay.
alveoli, where
What do we mean as lungs push their way out into primitive thoracic cavity? They take the lining visceral pleura with them to meet lining of body wall parietal pleura.
yeah, as the lungs grow into the thoracic cavity, they carry a layer of the pleura with them called the visceral pleura. This layer meets the parietal pleura, which lines the inside of the chest wall, forming a space between them, the pleural cavity.
So parietal inside, visceral outside.
Actually, it's the other way around. The parietal pleura lines the inside of the chest wall, while the visceral pleura covers the lungs directly.
Again.
Sure, parietal pleura lines the chest wall, and visceral pleura covers the lungs.
Mm-hmm.
It's a lot of terms, but you're getting it.
So how come? So the lungs push their way out into the primitive thoracic cavity. What does this mean?
So, as the lungs develop, they grow outwards from the central region into the space that becomes the thoracic cavity. As they do this, they pull a layer of pleura along, which forms the visceral pleura, while the parietal pleura lines the chest wall.
All right. So altogether, we have a gut tube, and then we have an endodermal bud inside. Why is it called endodermal?
It's called endodermal because it comes from the endoderm, which is one of the 3 primary germ layers in an embryo.
Can we
The
talk more
endoderm,
about? Let's talk more about the germ layers.
sure, the germ layers are 3 primary layers formed early in embryonic development. The ectoderm forms structures like skin and the nervous system. The mesoderm forms muscles, bones, and the circulatory system. And the endoderm forms internal organs like the lungs and gut.
Mesoderm, you said muscles and what else?
The mesoderm forms muscles, bones, the circulatory system, kidneys, and much of the reproductive system.
And the ectoderm, exoderm, what do you say?
The ectoderm forms the nervous system, skin, hair, nails, and parts of the eyes.
And why is the structure of these two germ layers? And where do they come from? And why is their structure like ideal for the parts that they're going to develop?
The structure of the germ layers is ideal because they each form in specific regions. The ectoderm is on the outer layer, making it perfect for forming skin and nerves. The mesoderm, in the middle, is great for forming supportive structures like muscles and bones. The endoderm, inside, forms the internal organs.
That makes
Each
sense.
layer's
And why do the germ layers need to be inside the gut tube?
The germ layers don't all need to be inside the gut tube. The endoderm forms the gut tube itself, while the mesoderm and ectoderm surround it. The layers differentiate and migrate to form specific tissues and organs, creating a complex body structure.
All right. So, okay, we have the endodermal bud inside the gut tube. And how was the endodermal bud born?
The endodermal bud or lung bud forms as a small outpouching from the endodermal layer of the gut tube. This happens around the 4th week of development, and it eventually grows and branches to form the lungs and airways.
So, how is the formation of tracheoesophageal septum connecting to the growth of the endodermal bud from the gut tube?
The tracheoesophageal septum forms as the lung bud grows from the gut tube, separating the trachea and esophagus. This ensures the respiratory and digestive tracts develop separately, preventing food from entering the airway.
I don't understand how they're connected.
No problem. The lung bud starts as a small outgrowth from the gut tube. As it grows, a wall, the tracheoesophageal septum, forms to separate the respiratory and digestive tubes. This allows the trachea and esophagus to develop separately.
So, does the tracheoesophageal septum grow from the gut tube or from the endodermal bud or from something else?
The tracheoesophageal septum forms as a partition from the gut tube. When the lung bud grows out, it helps define this septum, separating the trachea, front part, from the esophagus, back part.
So the endodermal bud grows bigger and forms the septum, or no?
Not quite. The endodermal bud grows to form the lungs and airways, while the septum forms as a separate structure from the gut tube, dividing the trachea and esophagus.
How does
The
it
two
form from the gut tube?
The septum forms as a ridge that grows inward from the walls of the gut tube, separating the front part, trachea, from the back part,
From what
esophagus.
from what cells?
The septum forms from mesodermal and endodermal cells in the gut tube's walls.
Alright, so we have this septum and it separates the esophagus from the trachea and the lungs. And we have the esophagus basically posterior, and we called it dorsal.
Exactly. The esophagus is positioned dorsally or posteriorly, while the trachea and lungs are ventral or
What is this?
anterior.
What is this dorsal foregut? What's the foregut part?
The foregut is the front part of the primitive gut tube, which later forms structures like the esophagus, stomach, and part of the respiratory system. So, the
Mhm.
dorsal foregut refers to the back portion of this early gut tube.
Okay. Why are the parietal on the outside and the visceral on the inside?
The parietal pleura lines the chest wall, while the visceral pleura covers the lungs. This arrangement allows the lungs to move smoothly
Can you
within the
explain
pleural
to me how the word name relates to the anatomical location?
Sure, parietal comes from the Latin word paries, meaning wall, so it lines the chest wall. Visceral comes from viscera, referring to internal organs,
Hmm,
so it covers the lungs.
makes sense. Can we talk about the hilum, root of the lungs now?
Sure, the hilum, or root of the lungs, is where structures like the bronchi, blood vessels, lymphatics, and nerves enter and exit the lungs. It's located on the medial aspect of each lung and is surrounded by pleura. Essentially, it's the gateway for everything entering or leaving the lungs.
So we have a hilum left and hilum right.
Each lung has its own hilum. The left hilum and the right hilum are similar in function but differ slightly in structure. For instance, the right hilum has more bronchi since the right lung has 3 lobes, while the left hilum has fewer, corresponding to the left lung's 2 lobes.
And we have pulmonary arteries and veins too.
Yes, definitely. The pulmonary arteries carry deoxygenated blood from the heart to the lungs, while the pulmonary veins return oxygenated blood from the lungs to the heart.
What other
Both sets of
what other holes do we have in the lungs?
So, besides the pulmonary arteries and veins, the bronchi also pass through the hilum. Additionally, lymphatic vessels and nerves are present. So you've got the bronchi, pulmonary arteries, pulmonary veins, lymphatics, and nerves all going through the hilum.
Hmm. So we have pulmonary veins, pulmonary arteries, hilum. What else?
Along with the pulmonary arteries and veins, you have the bronchi that carry air, as well as lymphatic vessels and nerves. These structures all pass through the hilum, making it a busy area for lung function.
So they pass through the hilum. Let me pull up a picture here.
Sure, take your time. I'm here when you're ready.
Hmm.
Whenever you're ready, we can go over the details together.
Okay. So that's the
Great,
hilum.
just let me know. All
What?
set?
So I don't understand. So the hilum is a separate structure from the blood vessels.
The hilum isn't a separate structure, it's more like a region or gateway on each lung. It's where the bronchi, blood vessels, lymphatics, and nerves all enter and leave the lung.
Wait. So you're
Think
saying that the vessels are inside the hilum?
exactly. The hilum is like a doorway, and the vessels, bronchi, lymphatics, and nerves pass through it to get in and out of the lung. So they're
Okay,
within that region.
makes sense. And
Glad that helped.
so tell me all the things inside the hilum then.
Sure, inside the hilum, you have the primary bronchi, pulmonary arteries, pulmonary veins, lymphatic vessels, and nerves. Each of these structures has a specific role, like carrying air, blood, or signals in and out of the lungs.
Primary bronchi, you said?
Yes, the primary bronchi. They branch off from the trachea and enter each lung through the hilum.
Hmm.
The right and left bronchi are slightly different in size and angle.
So we have superior pulmonary veins and inferior.
Exactly. Each lung has a superior and an inferior pulmonary vein. They carry oxygen-rich blood from the lungs back to the heart.
How about bronchial arteries?
Bronchial arteries supply oxygenated blood to the lung tissue itself. They typically branch off from the aorta and also pass through the hilum to reach the lungs.
Hmm.
Great. So, any other questions about the hilum?
Hmm.
No worries. We can take it step.
What do the bronchial arteries give?
Bronchial arteries provide oxygenated blood to the lungs, mainly to the bronchi and connective tissue.
So they're
They
basically a similar thing to coronary arteries for the heart.
Exactly. Just like coronary arteries supply the heart muscle, bronchial arteries supply the lung tissue.
Oh,
Both ensure the organs get the oxygen and nutrients they need.
cool. And so the talking about the parietal pleura, we have um, diaphragmatic, we have cervical, we have costal and mediastinal. Why do we call them cervical?
We call them cervical because they're near the top of the lungs, close to the neck region. The cervical pleura covers the apex of the lung, extending into the neck area.
Yeah, but what does cervical mean? Why does it represent something that's close to the neck?
Cervical comes from the Latin word cervix, meaning neck. So when we say cervical pleura, we're referring to the pleura near the neck region, at the lung apex.
Genius.
Glad it makes sense. Anything else on your mind?
So is the phrenic nerve the nerve supply of the parietal pleura then?
Yes, the phrenic nerve primarily supplies the diaphragmatic part of the parietal pleura, while the intercostal nerves supply the costal pleura. Each area gets its nerve supply based on its location.
Hmm.
If
The
you want more
phrenic
details on the
nerve.
nerve supply,
So how does the phrenic nerve help the parietal pleura? And how do the intercostal nerves here help too? And are the intercostal nerves T1 to 11?
The phrenic nerve mainly provides sensation to the diaphragmatic pleura and mediastinal pleura. It helps you feel sensations like pain in these areas. The intercostal nerves, T1 to T11, supply the costal pleura and peripheral parts of the diaphragmatic pleura, providing sensation to the chest wall and periphery of the diaphragm.
Yeah, but why T1, T11?
T1 to T11 are the intercostal nerves running between the ribs. They provide sensory innervation to the skin, muscles, and pleura in those areas,
Why
making
not?
them essential.
So why not T12?
T12 is actually called the subcostal nerve, running below the 12th rib. It functions similarly to the intercostal nerves, but is just named differently due to its position below the last rib.
So the intercostal nerves, okay, so we have one for each T1, T2, T3.
Exactly. Each intercostal nerve corresponds to a specific thoracic vertebra, from T1 to T11,
And
supplying the
and
areas.
what? All of them supply the parietal pleura?
Not all of them. The intercostal nerves supply the parietal pleura mostly in the costal region, while the phrenic nerve covers the diaphragmatic and mediastinal regions.
Hmm.
Each has its. Got it? It's a bit complex, but each nerve has its own.
Explain to me this. Visceral and parietal pleura connect to at the hilum of the lung? How is this possible?
Sure, the visceral pleura covers the lungs themselves, while the parietal pleura lines the chest cavity. They meet at the hilum because that's where the lung's surface transitions to the chest wall. This creates a continuous sealed space.
How do they connect at the hilum?
At the hilum, the visceral pleura folds back on itself to become the parietal pleura. This creates a continuous membrane, ensuring a smooth transition between the lung surface and the chest wall lining.
I just saw a diagram. Hmm. I think I see. So hmm. Hmm.
Exactly. It's a bit like a sleeve turning inside out, creating a seamless connection.
And why is the nerve supply different for the visceral? It's the visceral afferent autonomic nerves via the pulmonary plexus.
The visceral pleura has autonomic nerve supply, mainly from the pulmonary plexus, so it's less sensitive to pain. It primarily detects stretch or pressure changes.
What
In
the
contrast, the
what's
parietal
the
pleura
what's the
has some.
what's the pulmonary plexus and why is it less sensitive to pain?
The pulmonary plexus is a network of autonomic nerves around the lungs. It primarily controls involuntary functions like bronchoconstriction and dilation. The visceral pleura is less sensitive to pain because it lacks the somatic nerves that transmit sharp pain sensations. Instead, it mainly senses stretch or pressure.
Tell me more about the pulmonary plexus.
The pulmonary plexus consists of sympathetic and parasympathetic fibers. It regulates functions like bronchial muscle tone, mucus secretion, and blood vessel diameter. These autonomic nerves help control lung functions without conscious effort, making them crucial for respiratory processes.
Hmm. So, guys, we're gonna multitask with some respiratory pathophysiology. So, yeah, you'll see it in the title anyway. So, can we talk about the two different methods of measuring blood oxygen, arterial blood gases and blood O2 saturation, please? What's the differences?
Sure, blood oxygen can be measured using arterial blood gases, ABGs, or pulse oximetry. ABGs provide detailed info about oxygen, carbon dioxide, and pH levels directly from the blood. Pulse oximetry, on the other hand, is non-invasive and measures oxygen saturation via a fingertip probe. It's simpler but less detailed.
So, blood oxygen saturation is linked to hypoxia, and then arterial blood gases to hypoxemia. Explain.
Right, hypoxia refers to low oxygen levels in tissues, while hypoxemia is low oxygen in the blood. Blood oxygen saturation measures how much hemoglobin is carrying oxygen, while ABGs give a precise oxygen partial pressure. Both help diagnose and assess oxygen-related conditions.
Well, why is ABGs linked to hypoxemia and then blood O2 saturation is linked to hypoxia?
ABGs measure the exact partial pressure of oxygen in the blood, which directly indicates hypoxemia. Blood oxygen saturation, measured with a pulse oximeter, reflects how much oxygen hemoglobin is carrying, which helps identify hypoxia. Hypoxemia can lead to tissue hypoxia if not corrected.
Well, I understand the ABG's hypoxemia. I don't understand how the blood O2 saturation is measured from this oximeter. And also, I don't understand why the saturation. Okay, okay. Why does the saturation of oxygen with HB means low oxygen in tissues?
Pulse oximetry measures oxygen saturation using light absorption. It estimates how much hemoglobin is bound to oxygen. Low saturation means less oxygen is available for tissues, potentially causing hypoxia. It's not as precise as ABGs, but gives a quick overview of oxygenation.
Mm.
If you need more detail, we can break it down further.
So the pulse oximeter will detect hypoxia in the finger capillaries.
Exactly. Pulse oximetry measures the oxygen saturation in capillaries, usually at the fingertip.
But
It
it
gives a
won't,
quick,
so it's local, it won't actually detect it in let's say, the the fingers on my leg.
right, pulse oximetry gives a general idea of blood oxygenation, but it might not reflect issues in other body areas. It's a useful tool, but has limitations.
Hmm. And can blood out, can this, so what about hypercapnia? Can the pulse oximeter or the ABGs measure hypercapnia?
Hypercapnia, which is high carbon dioxide levels, is measured with ABGs, not pulse oximetry. ABGs provide a detailed analysis of oxygen, carbon dioxide, and pH levels, making them essential for detecting hypercapnia.
How do they do this? Is it because they will analyze the blood after?
Exactly. ABGs involve drawing a blood sample from an artery. This sample is then analyzed to measure oxygen, carbon dioxide, and pH, giving a complete picture of your blood gases.
Can we talk about SaO2 versus SpO2?
Sure, SaO2 refers to arterial oxygen saturation measured by ABGs. SpO2 is oxygen saturation measured by pulse oximetry. Both indicate how much hemoglobin is carrying oxygen, but SaO2 is more precise.
Why? Why? Sir.
So SaO2 is measured directly from arterial blood, which is more accurate than SpO2, which uses light absorption. This makes SaO2 a bit more precise.
Why is light absorption less good?
Light absorption can be affected by factors like poor circulation, skin pigmentation, or movement. It provides a good estimate, but it's not as precise as direct blood measurement.
Or you might have other gases and poisons interfering with HB binding to oxygen. And you might have like a high PaO2, but a low SaO2.
Exactly. Conditions like carbon monoxide poisoning can cause high PaO2 but low SaO2 because the hemoglobin is bound to something other than oxygen. ABGs help detect these issues.
So if you have hypoxia, does this mean that you also have hypercapnia?
Not necessarily. You can have hypoxia without hypercapnia. Hypoxia is low oxygen in tissues, while hypercapnia is high CO2 in the blood. They can occur together or separately depending on the underlying condition.
So they will appear together in terms of respiratory failure?
Yes, in respiratory failure, you might see both hypoxia and hypercapnia. The extent depends on the type and severity of the respiratory issue. ABGs are crucial for diagnosing and monitoring these conditions.
Hmm. Can you talk to me about how gases with higher solubility will have more gas molecules in the solution for the same partial pressure and how this affects us?
Sure, Gases with higher solubility, like CO2, dissolve more readily in blood at the same partial pressure. This means more CO2 can be carried in the blood, impacting acid-base balance. This is crucial for maintaining pH levels and respiratory function.
So we have four types of hypoxia. Huh? Sir.
Yes, there are four main types: hypoxemic, anemic, stagnant, and histotoxic hypoxia. Each has a different cause, from low blood oxygen to impaired oxygen use by tissues.
So let's talk about hypoxic hypoxia.
Sure, hypoxemic hypoxia occurs when there's low oxygen in the blood, often due to lung issues like pneumonia or high altitude. This reduces the oxygen available for tissues, causing symptoms like shortness of breath.
All
Feeling a bit overwhelmed? We can take it slow.
right.
No rush. Whenever you're ready, we can continue.
So what's the difference between hypopnea and dyspnea?
Hypopnea refers to abnormally shallow breathing, often during sleep. Dyspnea, on the other hand, is the sensation of shortness of breath or difficulty breathing, which can occur with various conditions.
Okay. So
Got it?
so hypopnea is a low minute ventilation.
Exactly. Hypopnea involves reduced airflow, leading to lower ventilation,
But
especially during sleep.
can someone with dyspnea not have hypopnea?
Yes, someone can have dyspnea without hypopnea. Dyspnea can occur with normal or increased ventilation, like in asthma or anxiety, where breathing is difficult but not shallow.
Hmm.
It's a subtle but important difference.
Can we compare N2 narcosis and CO2 narcosis?
Sure, nitrogen narcosis, often seen in divers, results from nitrogen's effects under pressure. CO2 narcosis, or hypercapnia, happens when high CO2 levels depress the central nervous system. Both can cause confusion and impaired consciousness, but have different underlying causes.
Hmm.
It's fascinating how gases affect our bodies, right?
Yeah, but I don't understand the difference between N2 narcosis and CO2. Is it if we have too much or too little?
Both involve having too much. Nitrogen narcosis results from excess nitrogen under high pressure, while CO2 narcosis comes from elevated CO2 levels in the blood,
And
causing
how can this happen?
nitrogen narcosis can happen during deep diving due to increased pressure. CO2 narcosis usually results from respiratory failure, where the body can't eliminate CO2 efficiently. Both are serious and need prompt attention.
Like opioids, do they create one of the two?
Opioids can cause respiratory depression, leading to CO2 narcosis. The slow breathing causing CO2 buildup, which can depress the central nervous system.
Okay.
Yep, that's why careful monitoring is crucial with opioids.
In compensatory breathing, is the point that we are going to remove CO2?
Exactly. Compensatory breathing increases to remove excess CO2 and to bring oxygen levels up. It's the body's way of balancing gases when there's an issue.
Hyperventilation, why can it not correct hypoxemia from a shunt?
Hyperventilation can't fix hypoxemia from a shunt because blood bypasses ventilated areas of the lung. More breathing doesn't help oxygenate shunted blood. The key issue is the anatomical or physiological shunt, not ventilation.
Mm-hmm. All right, and let's go back to the pleural cavity, to the pleural stuff. So we have pleural
Sure.
cavity. It's the space between the two pleura.
Exactly. The pleural cavity is the space between the visceral and parietal pleura,
And how is
containing a small.
yes, how is the serous fluid inside produced?
The pleural fluid is produced by both pleural layers. It's mainly from the parietal pleura's capillaries, and it's absorbed by the lymphatics. This balance keeps the fluid level just right.
Absorbed by the lymphatics.
Yes, the lymphatic vessels in the parietal pleura help reabsorb the excess fluid, maintaining the balance and preventing fluid buildup.
How do they do this?
They do it through small openings called stomata. These allow fluid and particles to drain into the lymphatic system, keeping the pleural space clear.
Okay, recess. What are these recesses in the pleural cavity?
Recesses are areas where the pleural cavity extends further, like the costodiaphragmatic recess. These spaces allow the lungs to expand during deep breaths.
So it's empty space that's like needed when we breathe.
Exactly. It provides extra room for the lungs to expand fully when you take a deep breath.
Mm-hmm.
Pretty neat how our body works, right?
Mm-hmm.
Anything else about the pleura you'd like to explore?
So we only have costal, mediastinal, and diaphragmatic surfaces. Why don't we have a nice cervical one too?
We do. The cervical pleura covers the lung apex and
Oh,
extends
sorry,
into the
sorry.
neck.
Lung surfaces.
Exactly. The cervical pleura is part of the lung surface at the top, near the neck region.
Yeah, but forget the pleura. Let's talk about the lungs. How many surfaces do you have? Lung surfaces.
The lungs have three surfaces: costal, mediastinal, and diaphragmatic.
Exactly.
Each corresponds.
And why don't we have a cervical one too?
The cervical surface is part of the costal surface near the apex. It's not usually listed separately, but is still there.
Yeah, it's part of the costal.
Yup, it all connects.
Okay, we have two fissures, horizontal and oblique, with the right lung.
Yes, the right lung has a horizontal and an oblique fissure, dividing it into three lobes: superior, middle, and inferior.
What does oblique mean?
The oblique fissure runs diagonally, separating the superior and middle lobes from the inferior lobe.
Wait a sec. So, okay, we have three lobes, superior, middle, and inferior. I don't understand the fee. So we have a horizontal fissure which separates the superior from the middle and inferior.
Almost. The horizontal fissure separates the superior lobe from the middle lobe. The oblique fissure separates both the superior and middle lobes from the inferior lobe.
Mm.
It's a bit confusing at first, but it all fits together.
Mm.
No worries, it
And,
takes a bit of practice to
and
visualize.
what's the lingula in a cardiac notch?
The lingula is a small, tongue-like projection on the left lung's upper lobe near the cardiac notch. It sort of corresponds to the middle lobe of the right lung.
And why do we have it?
The lingula is there because the left lung has only two lobes, and it helps compensate for the space taken by the heart in the cardiac notch.
Cardiac notch? What is this cardiac notch?
The cardiac notch is an indentation on the left lung to accommodate the heart. It creates space for the heart's apex.
Indentation? What is this?
An indentation is just a slight inward curve or hollow. In this case, it's the dip in the lung surface to make room for the heart.
I don't understand.
No problem. It's like a little dip on the lung's edge where the heart sits.
Interesting.
It is interesting. The body's full of clever adaptations.
Sorry, guys, I took a 1 minute break. Okay, let's continue. Okay, so we talked about the hilum. We talked about what it includes. Do we have lymph vessels and nodes in the hilum?
Yes, lymph vessels can be found in the hilum, particularly of organs like the lungs. The hilum is the area where structures such as blood vessels, nerves, and lymphatics enter and leave the organ. In the case of the lungs, lymph vessels drain lymph fluid from lung tissues and transport it through the hilum to lymph nodes.
And we find the pulmonary plexus too in the hilum of the lungs?
Yes, the pulmonary plexus is located around the hilum of the lungs. It's a network of nerves formed by branches from the vagus nerve and the sympathetic trunk. This plexus innervates the lungs, controlling functions like bronchoconstriction, bronchodilation, and regulating secretions.
Okay,
Exactly. It's a crucial area for lung function. Anything else you'd like to know about it?
you bet.
You got it. Anything else about the lungs? Sure. What's on your mind?
Guys, let's go back to the respiratory pathophysiology and all of that. So, can we talk about fractional inspired oxygen and fractional inspired CO2? What is this?
Sure. Fractional inspired oxygen, or FiO2, is the percentage of oxygen in the air mixture that you breathe in. It's especially important in medical settings when oxygen therapy is used. Fractional inspired CO2, or FiCO2, refers to the percentage of carbon dioxide in the air mixture. Both values are crucial for understanding respiratory function and gas exchange.
And this is kind of a standard amount then.
For FiO2, the standard amount in room air is about 21%. In medical settings, it can be adjusted higher if someone needs extra oxygen.
Wow.
As for
So you
FI,
adjust the oxygen in the room?
exactly. In hospitals, they can adjust the oxygen concentration for patients using devices like nasal cannulas or masks, ensuring they get the right amount of oxygen.
Okay, got it. And can you have fractional inspired oxygen 100%?
Yes, you can. That's what we call giving pure oxygen. It's often used in specific medical situations, like during surgery or for patients with severe respiratory distress, to maximize the oxygen available in the lungs.
All right. So in chronic bronchitis, are the alveoli um, inflamed or only the airways?
In chronic bronchitis, the inflammation mainly affects the airways, specifically the bronchi. The alveoli themselves aren't typically inflamed. The
And
condition causes
and the airways, we have an airway and then it connects to a bunch of alveoli.
exactly. The airways or bronchi branch into smaller tubes called bronchioles, which then connect to clusters of alveoli. These tiny air sacs are where gas exchange happens, allowing oxygen to enter the blood and carbon dioxide to be expelled.
And why were traditionally the lung problems divided into airways and alveoli, and now they're called COPD?
Traditionally, lung problems were categorized by their location, airways or alveoli. Chronic bronchitis was seen as an airway issue, while emphysema involved the alveoli.
Okay.
Now, they're grouped.
And what are digital physics?
Digital clubbing is when the tips
No,
of your fingers or
no. To be honest, tell me what digital clubbing is too. That's interesting.
sure thing. Digital clubbing is when the fingertips or toes enlarge and the nails curve around the fingertips. It's often linked to chronic low oxygen levels in the blood and can be a sign of various lung or heart conditions.
Why is this called digital?
It's called digital because it refers to the digits, meaning fingers or toes. The term clubbing describes the rounded, bulbous shape they take on.
And what is digital physics?
Digital physics is a theoretical framework suggesting the universe can be described by information, similar to how a computer operates. It proposes that the universe's fundamental processes are computational, with space, time, and matter emerging from underlying data
And what
structures.
is the difference between quantum computing and normal? Give me a sec. Sorry. So what's the difference between quantum and classical computing, I guess?
No worries. Classical computing uses bits as the smallest unit of data, which are either 0 or 1. Quantum computing, on the other hand, uses qubits, which can exist in multiple states simultaneously, thanks to superposition. This allows quantum computers to solve certain problems much faster than classical ones.
How can the qubits exist in multiple states?
Qubits can exist in multiple states due to a quantum property called superposition. Essentially, they can be in a state of 0, 1, or both at the same time. This allows quantum computers to perform complex calculations more efficiently.
Can you go a bit deeper, please?
Sure, think of a qubit like a spinning coin. While a classical bit is either heads or tails, a qubit can be in a combination of both until measured. This superposition is what gives quantum computing its power.
And who measures it?
Measurement in quantum computing is done by the quantum computer itself. When you measure a qubit, it collapses from its superposition state into either a 0 or 1, giving you a definite outcome.
So why is this faster since it eventually collapses anyway?
It's faster because while in superposition, qubits can perform many calculations at once. This parallelism allows quantum computers to solve certain problems much more quickly than classical
So
computers.
there is value in it before it gets collapsed.
Exactly. The real power lies in the qubit's ability to explore many possibilities simultaneously, which
But
dramatically speeds
okay,
up processing
and
for.
and how do we know? So well, w- why does it collapse to either a zero or a one? And like, when will it be a zero and when will it be a one, depending on what?
It collapses to a 0 or 1 based on probabilities defined by the qubit state. Before measurement, these probabilities are influenced by the qubit's position in superposition,
What you mean?
determined by. Basically, the qubit state before measurement gives us the likelihood of it collapsing to 0 or 1. It's all about the probabilities encoded in the qubit superposition.
I don't understand.
No worries. It's a tricky concept.
Well, explain it.
Sure, imagine a qubit as a spinning coin. Before you catch it, it has a chance to land heads or tails. In quantum terms, the probabilities of each outcome are determined by the qubit state, which is set by its preparation. When you measure it, the qubit collapses to a definite value, 0 or 1,
All
based
right.
on those probabilities.
Let's go back to pathophysiology, emphysema.
Sure, with emphysema, the alveoli or air sacs in the lungs become damaged. This damage reduces the surface area available for gas exchange, making it harder for oxygen to get into the blood.
Tell me again.
Sure, in emphysema, the tiny air sacs in the lungs, called alveoli, get damaged. This reduces the surface area for gas exchange, making it harder for oxygen to enter the bloodstream.
So alveoli are inflamed.
In emphysema, the alveoli aren't inflamed. They're damaged and lose their elasticity. This damage causes them to collapse, trapping air and making it harder to breathe.
Mm. So chronic bronchitis is mainly for airways, but emphysema now is because of the alveoli.
Exactly. Chronic bronchitis primarily affects the airways, causing inflammation and mucus buildup. Emphysema, on the other hand, damages the alveoli, reducing their ability to exchange gases.
And how do we test for this?
To test for these, doctors use lung function tests like spirometry. This measures how much air you can inhale and exhale and how quickly.
Well, how
Imaging
can we
tests,
make sure that the patient has emphysema and they don't have chronic bronchitis and vice versa?
spirometry can help distinguish between them. Emphysema typically shows reduced lung elasticity and air trapping, while chronic bronchitis often presents with airflow obstruction and increased mucus. A CT scan can also show damage to the alveoli in emphysema.
What's the difference between blue bloaters and pink puffers?
Blue bloaters typically refers to chronic bronchitis patients who may have lower oxygen levels, leading to a bluish tint. Pink puffers describes emphysema patients who often have normal oxygen but breathe rapidly to compensate for their damaged alveoli.
So blue bloaters is for chronic bronchitis, basically.
Exactly. Blue bloaters is associated with chronic bronchitis due to lower oxygen levels and symptoms like cyanosis.
Cyanosis. And why is the color blue the result?
The bluish color, or cyanosis, happens because of low oxygen levels in the blood. It gives the skin, especially around the lips and fingertips, a blue tint.
And let's talk about pink puffers now.
Sure, emphysema patients often have normal oxygen levels but struggle to breathe. They compensate by breathing rapidly, which can give them a pinkish complexion.
And why pink?
They're often called pink because despite their difficulty breathing, they maintain better oxygenation, so they don't develop the bluish tint seen in chronic bronchitis.
Okay, let me compare restrictive with obstructive lung disease. Restrictive, so in obstructive, we have a collapse, and in restrictive, well, one is basically restricts expiration and the other one inhalation. So if the lungs are collapsed, we cannot inhale. If we have restriction, it's like a chest is on our sorry, it's like a brick is on our chest and we can't exhale, right? No, wait. No, a brick is on our chest and we can't inspire. That's restriction.
You've got it. Obstructive lung diseases like chronic bronchitis or emphysema make it hard to exhale fully due to airway narrowing or collapse. Restrictive lung diseases like pulmonary fibrosis limit lung expansion, making it hard to inhale fully.
And an obstruction is because of trapped air, basically.
Exactly. In obstructive diseases, air gets trapped because the airways are narrowed or collapsed, making it hard to fully exhale.
And let me ask you a question. So, in restrictive, why does it happen? Give me a few disease examples.
Restrictive lung diseases can occur due to stiffness in the lungs or chest wall. Examples include pulmonary fibrosis, sarcoidosis, and conditions like scoliosis that affect the chest wall.
So, how do they affect the chest wall?
Conditions like scoliosis can deform the spine, which affects the shape
Bra,
and flexibility of the chest wall.
bra.
Limit
What is
fi-
sarcoidosis?
yes, sarcoidosis can cause granulomas, which are small areas of inflammation that can stiffen lung tissue,
And
contributing to restrict.
so, how can fibrosis do restrictive lung disease? And sorry, I interrupted. Tell me again about sarcoidosis too. Sarcoidosis.
No worries. Sarcoidosis causes granulomas, which can stiffen lung tissue, leading to restrictive lung disease. Fibrosis, on the other hand, involves scarring that thickens and stiffens the lung tissue, also restricting lung expansion.
And sarcoidosis, what is it?
Sarcoidosis is an inflammatory disease where tiny clumps of immune cells, called granulomas, form in various organs, most commonly the lungs. These granulomas can affect how the organs function, leading to symptoms and sometimes organ damage.
How do the granulomas affect? And also, talk to me about kivoscoliosis and other types.
Granulomas can cause organ stiffness and dysfunction by disrupting normal tissue structure. In the lungs, they can lead to fibrosis, and reduced lung capacity. As for scoliosis, there are several types. Idiopathic, most common. Congenital, present at birth. Linked to conditions like cerebral palsy.
Can we talk about tetralogy of Fallot? What's the four things?
Sure, we can definitely talk about tetralogy of Fallot. It's a congenital heart defect with four main features. These are ventricular septal defect, a hole between the heart's lower chambers, pulmonary stenosis, narrowing of the pulmonary valve, right ventricular hypertrophy, thickening of the right ventricle muscle, and an overriding aorta, where the aorta is positioned over the VSD.
And how can opiates create restrictive problems?
Opiates can cause respiratory depression, which means they slow down breathing. In severe cases, this can lead to hypoxia or low oxygen levels, which might cause restrictive lung problems over time. Chronic use can also lead to weakened respiratory muscles, making it harder for the lungs to expand.
Can we talk about the right to left shunts?
Sure, a right to left shunt happens when blood flows from the right side of the heart to the left, bypassing the lungs. This means oxygen-poor blood mixes with oxygen-rich blood, which can lower the overall oxygen levels in the bloodstream. It's often seen in congenital heart defects like tetralogy of Fallot.
Why does it decrease the oxygen levels?
It decreases oxygen levels because the blood skips the lungs, where it normally picks up oxygen. So the deoxygenated blood from the right side of the heart mixes with the oxygenated blood on the left side, resulting in less oxygen overall in the blood that circulates through the body.
Is there a possibility that the blood can circulate too fast and then the gas exchange and stuff like that can't happen?
Yes, that's possible. If blood circulates too quickly, there isn't enough time for proper gas exchange in the lungs. This can happen with certain heart defects or conditions that cause increased heart rate and cardiac output. As a result, oxygenation of the blood can be compromised.
So we call it venous admixture, but why don't we call it arterial admixture?
We call it venous admixture because the deoxygenated blood typically comes from the venous system. It mixes with oxygenated blood in the heart, resulting in lower oxygen levels. Arterial admixture isn't used because the problem originates from the venous side.
Why? Okay. Why does the problem originate from the venous side then?
The problem originates from the venous side because the deoxygenated blood coming from the body's veins isn't fully reoxygenated in the lungs before it enters the arterial system. This can be due to shunts, where blood bypasses the normal lung circulation route. So, the issue starts on the venous side and affects the arterial oxygen content.
I don't understand.
No worries. Basically, the venous side has blood that's low in oxygen. If this blood doesn't pass through the lungs properly to pick up oxygen, it stays poorly oxygenated. So, when it mixes with oxygen-rich blood on the arterial side, the overall oxygen level drops.
Wait, dude. So the blood, the well, the
So,
pulmonary. Where exactly does the shunt happen then? From the right atrium to the left?
it depends on the specific heart defect. In tetralogy of Fallot, for example, the shunt typically happens through the ventricular septal defect, allowing blood to flow from the right ventricle to the left. Other defects might involve the atria or different pathways.
But why is it venous admixture? Because the left ventricle will go to the arteries.
It's called venous admixture because the source of the deoxygenated blood is from the venous side. Even though it ends up in the arteries,
Got it.
the mixing problem.
But
So,
what about the other way around? Why is it always right to left shunt, never left to right?
actually, there can be left to right shunts too. In those cases, oxygenated blood from the left side flows into the right side, usually due to a defect. That can cause its own set of problems, like overloading the lungs with too much blood flow.
Hmm.
Each type of shunt affects the heart and lungs differently, which is why they have distinct names and implications.
Okay, so we have bronchial arteries supplying oxygen to the lung and the visceral pleura, but not oxygen to the parietal pleura?
Exactly. The bronchial arteries supply oxygenated blood to the lungs and visceral pleura. The parietal pleura, on the other hand, gets its blood supply from the systemic circulation, typically from the intercostal arteries.
And why is the left bronchial artery from the descending aorta and the right bronchial artery from the intercostal arteries?
That's because the left bronchial artery often branches directly from the descending aorta, while the right bronchial artery usually comes from one of the upper intercostal arteries.
Yeah, I didn't ask you to repeat what I said. I asked you why.
Got it. It's mainly anatomical variation. The left bronchial artery comes from the descending aorta due to the proximity and direct branching, while the right bronchial artery often arises from the intercostal arteries because of different embryonic development patterns.
And lungs are drained by bronchial veins where?
The bronchial veins typically drain into the azygos vein on the right and the accessory hemiazygos, or left superior intercostal vein on the left. This helps return deoxygenated blood from the lungs back to the heart.
Got it. And let me ask you a question then. They drain to the azygos. Where exactly do the bronchial veins branch on the lungs? Is it in the hilum again?
Yes, the bronchial veins are typically found near the hilum, where they collect blood from the bronchial circulation. From there, they join the larger veins like the azygos system for drainage.
All right, let's talk about the nerve supply of the lungs then. We have parasympathetic and sympathetic innervation. In the parasympathetic, we have contraction of bronchial musculature and constriction via vagus nerve. What is this bronchial musculature?
The bronchial musculature refers to the smooth muscle surrounding the bronchi and bronchioles. When parasympathetic nerves stimulated, it contracts, causing bronchoconstriction, which narrows the airways. This is part of the body's way to regulate airflow and protect the lungs.
Interesting. Okay, and we have sympathetic innervation, relaxation of the bronchial muscle. Okay, makes sense. So sympathetic chains are T1 to T5, and we also have intercostal veins in T1 to T11.
Yes, that's correct. The sympathetic innervation for the lungs comes from the T1 to T5 spinal segments, leading to bronchial muscle relaxation. And yes, the intercostal veins, which run along the ribs, drain into various veins, including the azygos system, from T1 to T11.
So why is it anatomically advantageous for the sympathetic chains to be in T1 to 5?
It's advantageous because those segments are close to the lungs, allowing for efficient nerve pathways to regulate bronchial dilation and constriction. This proximity ensures quick responses to stress, like during a fight or flight response, where the body needs to adjust airflow rapidly.
So it's close to the lungs, basically.
Exactly. That closeness ensures the nerves can act quickly and efficiently.
Hmm.
Yup, it's all about efficient communication.
Okay, that makes sense.
Awesome. Glad it's clear now.
Oh, dude.
Any other questions on the topic?
Well, yeah.
Great. What's next?
So lymph drains towards the hilum.
Exactly. Lymph from the lungs generally drains towards the hilum and then into the hilar lymph nodes before moving to other lymphatic structures.
So we have a bunch of nodes here. Let's talk about them. We have bronchopulmonary hilar nodes. We have inferior tracheobronchial carinal node. We have left bronchomediastinal trunk, thoracic duct, tracheal, paratracheal node. We have right lymphatic duct, right bronchomediastinal trunk. We have superior tracheobronchial node, bronchopulmonary hilar nodes. So, okay, right lymphatic duct we talked about yesterday. Thoracic duct we talked about yesterday. So we have left and right bronchomediastinal trunk we talked about. We have inferior and superior tracheobronchial nodes, and then we have bronchopulmonary nodes, which are hilar. Okay.
Exactly. The bronchopulmonary or hilar nodes are at the hilum. inferior and superior tracheobronchial nodes are near the trachea and bronchi. The left and right bronchomediastinal trunks collect lymph from these nodes before draining into the thoracic.
Can we put them into a pathway so I figure them out?
Sure, lymph from the lungs first drains into the bronchopulmonary hilar nodes. From there, it moves to the inferior and superior tracheobronchial nodes. After that,
Wait,
lymph travels to the
step by step.
bronchomediastinal trunk.
Step by step. So you said bronchopulmonary hilar nodes, then?
All right, step by step. First, lymph drains into the bronchopulmonary hilar nodes. Next, it moves to the inferior and superior tracheobronchial nodes.
Bronchotracheal.
Right, then from the tracheobronchial nodes, it travels to the bronchomediastinal trunks.
And then?
And finally, the bronchomediastinal trunks drain into either the thoracic duct on the left or the white lymphatic duct.
That was good. Okay. Let's talk about the respiratory tree. So it starts in the head and neck. How come?
The respiratory tree starts in the head and neck because it includes the nasal cavity, pharynx, and larynx, which are the initial passageways for air before it reaches the trachea and lungs.
So it ends with the terminal bronchioles, which give rise to respiratory bronchioles. I would assume that respiratory bronchioles came before the terminal. Terminal sounds like they're the last ones.
That's a common assumption, but it's the other way around. Terminal bronchioles are the last purely conducting airways, while respiratory bronchioles are where gas exchange begins.
Aha,
The respiratory bronchioles have
got it.
alveoli.
Gee.
Exactly. Hey there.
No,
What's
so,
up?
sorry guys, I changed the voice because it gets really low and I think you guys won't hear it. So, okay, got the respiratory portion, respiratory bronchial. Okay, so respiratory bronchioles, we have alveoli there and all of that.
No worries, I can hear you fine. So you're talking about the respiratory portion of the lungs, right? The respiratory bronchioles, the alveoli, and all those structures?
Yeah, each respiratory bronchiole gives rise to 2 to 11 alveolar ducts. Can you explain to me why 2 to 11 is the ideal number?
Absolutely. The branching from respiratory bronchioles to alveolar ducts is optimized for efficient gas exchange. Having around 2 to 11 branches means there are enough pathways to create a large surface area for oxygen and carbon dioxide to diffuse between air and blood, while still maintaining efficient airflow. This balance is crucial for our lungs to function effectively.
And each alveolar duct gives rise to 5, 6 alveolar sacs. Wow. Okay, that's so cool. Let's talk a bit about the trachea then. So we have its flexible tube found between C6 and T4, T5. So remind me, C6 is above T4, T5?
Hey, let's keep it friendly. C6 is indeed above T4, T5. In the spine, C6 is a cervical vertebra, while T4 and T5 are thoracic vertebrae, which are lower down in the spinal column.
And then in the carina it bifurcates. Okay. And when it bifurcates, we have primary bronchi.
That's right. The carina is the point where the trachea splits into the left and right primary bronchi. These bronchi then lead into each lung, and from there, they branch out further into smaller.
Sorry.
Exactly.
Yeah. And okay.
And then
And
the
what is this trachealis muscle? And what is this anterolaterally 20 C-shaped cartilage rings?
great question. The trachealis muscle is a band of smooth muscle along the back of the trachea. It helps adjust the diameter of the trachea for airflow. The trachea itself is supported by about 20 C-shaped cartilaginous rings that keep it open and prevent collapse.
Hmm.
Right, these rings are open at the back where the trachealis muscle is, allowing for flexibility and movement when swallowing or coughing.
So mucous membrane and cilia. What's this?
The mucous membrane lines the trachea and produces mucus, which traps dust and pathogens. The cilia are tiny hair-like structures that move in a coordinated way to sweep mucus and trapped particles up towards the throat, helping to keep the
One more time about these two things, please.
Sure. The mucous membrane produces mucus to trap dust and microbes. Cilia, which are tiny hair-like structures, move in unison to push that mucus up towards your throat, keeping your airways clean.
So cilia clean up. How do they do this? Tell me again about the mucous membrane.
Exactly. Cilia sweep the mucus upwards, carrying trapped particles out of the lungs. The mucous membrane lines the airways and produces mucus to trap dust, bacteria, and other particles, keeping your respiratory system clear.
I don't understand. Change the way you're telling it to me.
Got it. Cilia act like tiny brooms, sweeping mucus and trapped particles out of your lungs. The mucous membrane is like a protective lining that catches dust, germs, and other stuff before they get deeper into your airways.
Whereas cilia,
Cilia are tiny, hair-like structures lining your airways. They move in a coordinated way to push mucus and any trapped particles up and out of your respiratory tract.
so mucous membrane is a membrane, cilia push it out.
Exactly. The mucous membrane traps particles with mucus, and cilia move that mucus out of your airways, keeping them clear.
Why is the right main bronchus wider, shorter, and runs more vertically?
The right main bronchus is wider, shorter, and more vertical because of the way it branches off the trachea. It's almost a straight path into the right lung, which makes it easier for objects to get lodged there if inhaled.
And then after the primary bronchi, you have secondary.
Exactly. After the primary bronchi, they branch into secondary bronchi, which lead to each lobe of the lungs. The right lung has 3 secondary bronchi, and the left has 2.
So one bronchi for each lobe.
That's right. Each secondary bronchus serves one lobe. This setup ensures that air is evenly distributed throughout the lungs.
Then we have segmental / tertiary bronchi.
Exactly. The secondary bronchi branch into segmental or tertiary bronchi, which supply air to specific regions within each lobe.
Hmm.
These smaller bronchi ensure that air reaches every part of the lung efficiently.
We have 8 to 10 in the left and 10 at the right.
Exactly. The left lung usually has about 8 to 10 segments.
And what do we
While the
mean?
right lung,
What do we mean when we say each segmental bronchus supplies a bronchopulmonary segment?
a bronchopulmonary segment is a distinct region of the lung, each with its own air supply from a segmental bronchus. These segments are functionally independent, meaning they have their own blood supply and connective tissue boundaries.
Explain this a bit more to me.
Sure, each bronchopulmonary segment is like its own mini lung section. It has its own airway and blood vessels. So if one segment is affected by disease, the others can still function normally.
What is this bronchopulmonary segment? How does it differ from a tertiary bronchi?
The bronchopulmonary segment is the actual lung tissue region served by a tertiary or segmental bronchus. The tertiary bronchus is the airway that supplies air to that specific segment.
So it's the largest subdivision of a lobe.
Exactly. It's the largest subdivision within a lobe, each with its own bronchus and blood supply, making it a functionally independent unit.
And the pulmonary artery has branches, and each branch goes to a bronchopulmonary segment.
Exactly. Each bronchopulmonary segment gets its own branch of the pulmonary artery.
Dude, are people naturally interested in medicine, or are they just doing it for morals or money? Because I'm doing it for morals, but I'm just saying.
People have different reasons for going into medicine. Some are driven by a passion for helping others. Some are fascinated by science. And others may consider job stability or financial reward.
Well,
It's great.
I'm fascinated by science, but like this amount of detail about the bronchi seems like it's not difficult. It's just boring, I guess.
I get that. Some details can feel tedious. It's normal to find certain aspects less engaging, even if you love science. Focusing on how it all fits into the bigger picture might help make it more interesting.
Alrighty.
Glad to hear it. If you ever want to chat more or need a break, I'm here.
What do we mean 20 to 25 generations of conducting bronchioles?
The generations refer to the branching levels. The trachea splits into bronchi, then bronchioles, and so on. There are about 20 to 25 levels of these branches before reaching the tiny alveoli where gas exchange happens.
Do you mean that we have primary is the first generation, secondary is the second?
Exactly.
Jesus
The primary bronchi.
Christ. Oh God, I would have never guessed that.
It can definitely be surprising. The complexity of the respiratory system is pretty fascinating once you dive in.
So, do we have cartilage in the bronchi?
Yes, we do. The bronchi have cartilage rings or plates that keep them open, similar to the trachea, but they become less prominent as the airways get smaller.
And do we have cartilage in the walls?
Yes, especially in the larger bronchi.
But
The
not in the
cartilage helps.
smaller ones.
Exactly. In the smaller bronchioles, cartilage is absent, and they're mainly supported by smooth muscle.
So, how many generations we have that are respiratory bronchioles? Basically, only the first few are not respiratory.
Right. The respiratory bronchioles are found after about 16 to 20 generations. The earlier branches are mainly for conducting air, not gas
Okay,
exchange.
can you name me all the generations?
Sure. It starts with the trachea, then primary bronchi, secondary bronchi, tertiary bronchi, and then bronchioles. This continues through about 20 to 25 generations,
Go.
ending in out. You're welcome.
No,
Anytime.
no, go. Tell me all of them.
All right. So we have the trachea, primary bronchi, secondary bronchi, tertiary bronchi, then bronchioles, which include terminal bronchioles, and finally respiratory bronchioles
But
leading to alveolar duct.
but this is not
You're welcome.
25.
You're right. I simplified a bit. The 20 to 25 generations include all the branches.
Well,
From the trachea down.
don't simplify.
Sure. The main idea is that the airways keep branching from the trachea to the tiniest bronchioles.
Sir, I don't want the main idea. I want to know all of 25.
The trachea branches into primary bronchi, then secondary bronchi.
Keep going.
The terminal bronchioles lead to respiratory bronchioles, then alveolar duct.
Can we talk about type 1 pneumocytes and type 2 pneumocytes, please?
Sure. Type 1 pneumocytes are thin cells that form the walls of alveoli, allowing for gas exchange. Type 2 pneumocytes produce surfactant, which reduces surface tension, preventing alveolar collapse.
Tell me again, bud.
Sure. Type 1 pneumocytes are thin cells that enable gas exchange in the alveoli. Type 2 pneumocytes produce surfactant, which prevents alveoli from collapsing and aids in repair.
Okay.
Great. If you have more questions, feel free to ask.
All right. Let's go back to respiratory pathophysiology.
Sounds good. What aspect of respiratory pathophysiology are you interested in?
Let's talk about VQ mismatch.
Sure. VQ mismatch happens when ventilation, airflow, and perfusion blood flow in the lungs aren't properly matched. This can reduce oxygen in the blood and is often seen in conditions like pulmonary embolism or COPD.
Or pneumonia.
Exactly. In pneumonia, areas of the lung can be filled with fluid or infection, disrupting ventilation and leading to VQ mismatch.
So
This
in
makes it
pneumonia, we basically block the hilum.
Not the hilum specifically, but certain lung areas. The infection fills alveoli with fluid, reducing ventilation in those regions, which can affect overall gas exchange.
Hmm. Yeah, sorry. Tell me again.
No worries. In pneumonia, the infection fills alveoli with fluid, which reduces airflow in those areas and causes a mismatch between airflow and.
Yeah, that makes sense. Okay. So, um, can we talk a bit about pulmonary fibrosis? Basically, we have scar tissue.
Sure, pulmonary fibrosis is a condition where the lung tissue becomes scarred and stiff. This scarring makes it harder for your lungs to work properly, leading to symptoms like shortness of breath and a dry cough. It's often progressive, meaning it tends to worsen over time.
Can we talk a bit about the AA gradient?
Absolutely. The AA gradient, or alveolar arterial gradient, measures the difference between the oxygen concentration in the alveoli and the arteries. It helps assess how well oxygen is being transferred from the lungs to the blood. A normal gradient suggests efficient gas exchange, while an elevated gradient might indicate issues like ventilation-perfusion mismatch or diffusion
So
impairment.
we want more alveoli or more in arterial?
We generally want more oxygen in the alveoli than in the arterial blood, which drives the oxygen transfer. A small gradient is normal, indicating good oxygenation. If the gradient is too high, it means there's a problem with oxygen transfer from the alveoli to the blood.
When you're saying too high, you mean it's steep, basically.
Exactly, a steep gradient means a larger difference between alveolar and arterial oxygen levels. This suggests some issue like impaired gas exchange, ventilation-perfusion mismatch, or diffusion limitations. It's often seen in conditions like pulmonary fibrosis, where scarring affects oxygen transfer.
Hmm.
Yeah, it's a helpful measure for understanding lung function.
Why do we have this gradient?
The gradient exists because oxygen has to move from the air in the alveoli into the blood. The difference in oxygen levels creates a pressure gradient that drives this transfer. If everything's working well, the gradient is small. But if there's a problem with oxygen transfer, the gradient becomes larger.
Can we talk about how the gradient becomes larger in diffusion limitation? So we have thick tissue, let's say.
Sure, in diffusion limitations like with thickened or scarred tissue in pulmonary fibrosis, oxygen has a harder time passing from the alveoli to the blood. This increases the AA gradient because there's a bigger difference between the oxygen levels in the alveoli and the
And
blood.
and what happens to this built blood in the alveoli? The built oxygen, sorry.
When oxygen builds up in the alveoli because it can't diffuse properly, it means the blood doesn't get oxygenated efficiently. This results in lower oxygen levels in the blood, which can cause symptoms like shortness of breath and fatigue. Over time, this can put strain on the heart and other organs that rely on oxygen.
Interesting.
It really is. The body's intricate balance can be easily disrupted by something like scarring, but understanding these gradients helps diagnose and manage these conditions.
Um,
Yeah, and it's fascinating how these small changes can give us so much insight into lung health.
um, let's talk a bit about transit time, capillary transit time, and how it differs between AA gradients.
Sure, capillary transit time is the time it takes for blood to pass through the lung capillaries, where gas exchange happens. Normally, it's about 0.75 seconds, which is enough for oxygen to diffuse into the blood. If transit time is reduced, like during exercise, or if there's a diffusion issue, it can affect oxygenation. The A
0.75, you said?
right, it's usually around 0.75 seconds at rest. This gives enough time for oxygen to diffuse.
The same as a
During
heartbeat?
it's close. A heartbeat is about 1 second. So transit time is a bit shorter. This means blood has enough time to pick up oxygen and drop off carbon dioxide efficiently.
What do you mean? 0.25 is for CO2?
Exactly. Carbon dioxide diffuses out of the blood into the alveoli even faster, typically within about 0.25 seconds. This ensures efficient gas exchange, even during exercise or when oxygen demand increases.
Hmm. Okay, pulmonary
So,
edema. Um, how do
yeah,
how does it connect with diffusion limitation?
pulmonary fibrosis thickens the alveolar walls,
Pulmonary
creating a
edema.
diffusion. Pulmonary edema, on the other hand, involves fluid in the alveoli, also impeding gas exchange. This increases the AA gradient as well, making oxygen transfer less efficient.
That makes sense. And will it cause a vacuum mismatch, a pulmonary edema?
Yes, pulmonary edema can cause a ventilation perfusion mismatch. The fluid-filled alveoli can't effectively exchange gases, leading to areas of the lung that are well perfused but poorly ventilated.
Can we talk about Kussmaul breathing?
Sure, Kussmaul breathing is a deep, labored breathing pattern often seen in metabolic acidosis, like diabetic ketoacidosis.
What
Yeah, it's a compensatory mechanism to reduce
What
acid.
is this Kussmaul breathing?
Kussmaul breathing typically results from severe acidosis, where the body needs to correct blood pH. It's most commonly associated with diabetic ketoacidosis, but can also be seen in other conditions causing metabolic acidosis, like kidney failure or lactic acidosis.
Tell me again.
Sure, it's basically the body's way of trying to stabilize pH by breathing off excess carbon dioxide.
Don't understand.
You're welcome. Happy
I,
to help.
no, I said I don't understand. I said, what is this Kussmaul breathing?
Oh, got it. Kussmaul breathing is a type of deep, rapid breathing. It's the body's response to severe acidosis, like in diabetic ketoacidosis. The goal is to reduce acid levels by exhaling more CO2.
Yeah, so it's hyperventilation.
Exactly. It's a form of hyperventilation, but specifically in response to metabolic acidosis.
And why is it called Kussmaul?
It's named after Adolf Kussmaul, a 19th century German physician who first described the breathing pattern in patients with diabetic ketoacidosis.
Okay, guys, we'll talk tonight. See you, love you.